Welcome to this explainer. I am so glad you're here today because we're about to completely dismantle everything you think you know about depression. We're pulling back the curtain on a widely misunderstood topic and breaking down the actual mechanics of what's happening inside the brain and the body. If you've ever felt confused by this condition, or if you just love understanding the deep, fascinating biology behind human behavior, well, you're definitely in the right place. Let's jump in.
You assume you know what depression feels like. You don't. Look, we've all been sad before, right? So it is incredibly easy to just assume you understand the baseline. But ordinary sadness has a reason, and more importantly, it has an expiry date. Major Depressive Disorder, that is a totally different beast. It is absolutely not ordinary sadness.
And that brings us to the core thesis of this entire explainer. Same surface, completely different machinery underneath. The outward symptoms might look identical to anyone on the outside, the exhaustion, the totally flat mood, but the biological engines driving them are vastly different. Understanding this is literally the key to making sense of it all. So let's dive into exactly how this works. Starting with Section 1, Beyond Ordinary Sadness, where we'll look at the baseline conditions. There is a really stark contrast between ordinary sadness and major depressive disorder. MDD requires at least 2 solid weeks of a flattened mood or a total loss of pleasure, accompanied by sleep just falling apart, big appetite swings, and your concentration basically evaporating. But here's the incredibly cruel catch of MDD. The illness that desperately requires you to go get help is the exact same illness that strips away your motivation to want anything at all.
Now, this builds into something even sneakier: persistent depressive disorder, or PDD. This isn't your dramatic, can't-get-out-of-bed kind of depression. It's this low, gray, functional baseline that can last for years. The tragic trap here is that people don't even recognize it as an illness. They just assume this hollow feeling is their actual personality. And if a major depressive episode lands on top of that flat baseline, clinicians call it double depression. The tragedy isn't just the intensity, it's that the person has literally forgotten what normal feels like.
Getting the diagnosis right is absolutely critical, because bipolar depression looks completely identical to major depression from the outside. Same despair, same flat mood. But if a doctor just hands someone a standard antidepressant without a mood stabilizer, wow, that medication can tip a vulnerable bipolar brain straight into mania. The treatment for one type of depression becomes a massive trigger for another, all because of one missed question about whether the patient has ever experienced periods of mania.
Moving right along to Section 2, Biology, Clocks, and Hormones, the Mechanical Triggers.
These mechanical, biological triggers run on a very strict schedule. With seasonal affective disorder, or SAD, the trigger is actually a lack of light throwing off your circadian rhythm. You're basically treating a brain that is starving for a sunrise. With postpartum, the trigger is a massive post-birth hormone crash. And with PMDD, it's tied strictly to the menstrual cycle.
Let's take the postpartum experience, for example. We really need to separate the passing baby blues, those teary, overwhelmed days right after birth that resolve on their own, from the crushing reality of postpartum depression. PPD is a full depressive episode. Hormones crash right through the floor, combined with absolutely zero sleep and a body in recovery. And it comes wrapped in terrible guilt because society tells you you're supposed to be glowing. Also, a vital note here. This does not only hit mothers, it quietly strikes new fathers too, and nobody warns them about it either.
Then there's PMDD, where the reaction is in the brain, not the blood work. It's often cruelly dismissed because doctors run hormone tests and they come back perfectly normal. But the issue isn't abnormal hormone levels, it's the brain's shockingly abnormal sensitivity to the normal rise and fall of those hormones. For some people, it is quite literally the absolute worst week of every single month, on repeat for decades.
Okay, Section 3, the unexpected extremes, where we shatter the stereotype.
We are about to completely break the traditional mold of that weeping, sleepless patient. The irony of atypical depression is that the name is basically a lie. There is nothing rare about it. Its signature is mood reactivity. Something good happens, and you actually feel a genuine, brief, false dawn of pleasure before the mood plummets again. Because you can still laugh at a joke, friends and family might entirely miss the diagnosis. Add to that a heavy, leaden feeling in your limbs, like you're moving through wet cement, and a highly cranked-up radar for rejection, and you have a deeply misunderstood condition.
On the exact opposite end of the spectrum, we have melancholic depression, the system that registers joy. It just goes entirely offline. Absolutely nothing reaches you. Not good news, not your favorite food. This is a heavily biological form that runs on a daily schedule. Mornings are just brutal, and patients often wake up at 3 or 4 a.m. to just lie there in total despair. You can have a wonderful life and a loving family and still be completely flattened by it, because biology is driving the bus here.
This is where depression stops lying quietly and starts inventing things. We're preparing for a major escalation in symptom severity right now as we step into the terrifying realm of psychosis.
This is the terrifying reality of psychotic depression. It's a severe depressive episode with hallucinations or delusions bolted directly onto it. It creates this horrific, self-confirming loop. The depression builds a case that you're worthless or guilty, and then the psychosis literally supplies the fake auditory or visual evidence to prove it. Patients very often hide this out of intense fear of how crazy it sounds, which means they miss out on the vital combination of an antidepressant and an antipsychotic, or even ECT, that they actually desperately need.
And then we have catatonic depression. This entirely dismantles the persistent myth that physical catatonia only belongs to schizophrenia. Severe depression can literally switch a person off. The most eerie reality of this is waxy flexibility, where a person's limbs stay exactly where you pose them, just frozen in midair. A body becomes completely locked. But the strange mercy here is that this specific state often responds dramatically, sometimes within hours, to the right specific medications.
Which brings us to Section 4, Situations and Solutions, looking at the role of environment and treatment resistance.
Situational depression happens when a specific life event just knocks an adult flat. It's meant to fade as you adjust, but observers often unfairly dismiss it, telling the person they should be over it by now. Contrast that with PMDD, a childhood diagnosis characterized by a baseline of constant irritability and explosive temper outbursts. Just as adults are unfairly dismissed, these kids are unfairly punished. Observers treat the child as the problem, completely missing that the child is drowning in an illness that's driving the behavior.
The plan didn't work. Imagine the sheer hopelessness of failing multiple medications, spending months or years cycling through pills where every failed attempt chips away at your belief in recovery. That's treatment-resistant depression. But here is the enthusiastic silver lining I really want you to take away. Resistant does not mean hopeless. It just means the easy options are out, and it's time for the heavy hitters. Things like ketamine, which works in hours, TMS, using magnets to wake up brain regions, or ECT. There are real solutions.
And finally, Section 5, the hidden imposters, smoke from a different fire.
This brings us to our biggest twist yet. What if the depression isn't in your mind at all? What if everything that looks perfectly like a psychiatric illness is actually a physical poisoning or a mechanical bodily malfunction? There are entirely physical culprits hiding right in the shadows. Take substance use. People use alcohol to escape a low mood, but alcohol is literally a depressant. The substance deepens the low, so you use more. The escape hatch becomes a trapdoor. And consider the medical conditions: an underactive thyroid, Parkinson's, strokes, vitamin deficiencies. A patient comes in describing classic depression, gets treated for depression, and slowly gets worse because the real driver was a missed medical issue. The sadness was just smoke from a different fire.
That brings us to the core takeaway of our entire explainer. Depression isn't one disease. It's a final common symptom that dozens of very different problems can produce. If you remember literally nothing else from today, remember this: getting the specific type of depression right is the absolute foundational key to recovery.
I'm going to leave you with this final provocative thought. The word depression tells us how someone feels. It tells us almost nothing about why. But precision, biology, and asking why, that is the only true path to healing. Thank you so much for joining me to explore the mechanics behind this illness. Keep asking why and keep learning.